A 46-year-old attends a gynecology department with a lesion which is being shown on her vulva. And there is no associated itching, but there is a painless regional lymphadenopathy, which is a very important clue to say. So it is a very classical thing about primary syphilis, syphilitic chancre, which is called hard chancre, is typically associated with a painless lesion and also painless lymphadenopathy. Now, 37-year-old comes to the clinic with a painless vulval ulcer of 4 days duration. She has a papule initially, which later became ulcer, and bilateral lymphadenopathy was observed. So, multiple lesions, bilateral lymphadenopathy, and painless vulval ulcer. Once more points towards soft chancre, that would be chancroid, which is caused by Haemophilus ducreyi, is what you have to basically remember. 28-year-old comes with acute urinary retention, and she is already on the oral antibiotics, and painful multiple shallow ulcers, which is a very characteristic feature of herpes simplex. There are two types, type 1 and type 2. Type 1 is above the umbilicus, type 2 is below the umbilical lesions, is what you classically come across. 45-year-old is having inflammatory bowel disease, and ultrasound is being shown in the figure, and her periods are regular, and she denies any intermenstrual bleeding, and her pap smear results were also normal. So what is the most likely possibility of a lesion which you are seeing on the ultrasound? So classically it is a case of a fibroid, and in this given case it is a fundal fibroid, and what do you want to do with that if it is asymptomatic? A lot of women who undergo ultrasound beyond the age of 45 typically can have asymptomatic fibroid. There is nothing really need to be done if there is no intermenstrual bleeding or excessive bleeding or anything. It's not an indication for hysterectomy. That's a take-home point that you need to appreciate. 36-year-old nulliparous woman, secondary infertility. She has got regular heavy periods lasting for about 7 days every month. Ultrasound is being shown to you. So there is a submucosal fibroid which is altering the endometrial architecture, virtually acting like an intrauterine contraceptive device. Just like IUCD, if you keep the way it affects the endometrium, a submucosal fibroid also will affect like that. And unless you do the submucosal resection of the fibroid, fertility does not resume, is what you have to basically appreciate. A 62-year-old with a mass which is descending per vaginum, and she underwent total abdominal hysterectomy. A lot of times when the granima reaches 65-70 years of age, and she produced around 5 to 6 children and ultimately undergone hysterectomy. So there is a lot of pelvic muscle weakening, and that lead to development of a vault prolapse. So in this given case, what is the best treatment you want to do? Because of her age, you have got different procedures available for prolapse. Remember, doctor, prolapse is one topic in Shaw's gynecology. You have to read with certain passion. Otherwise, every time they ask a question, if you are not sure, when will you do Lafort, when will you do Fodogil, when you do pessary, etc., etc. So, Shirotkar's procedure. So, all these things, indications, complications, advantages, disadvantages, tips mein rehna hai. Definitely they will ask a question. So, open sacroplexy is the one, open or abdominal sacrocolpoplexy is the one for vault prolapse. 93% success rate is what need to be remembered. So that is, you are taking the help of the sacrum to stabilize the vault from drooping down. So that is what basically you are going to do. 15-year-old, primary amenorrhea, secondary sexual characters are normal, and she recollects having cyclical abdominal pain. Her FSH is 10 international units per ml and LH is 11. And the ultrasound of the pelvis shows a right ovarian cyst, and vaginal examination is being shown to you. So what do you see in this young 15-year-old girl presenting with primary amenorrhea? There is a transverse vaginal septum, and all the blood is coming and stagnating behind that, menstrual blood. So that is the reason you need to do the septal resection. Abdominoperineal septal resection is considered to be the clinical management of choice. So this is how typically it can present like an abdominal swelling because of all that blood that got insufficiented, and this is a typical appearance of the vaginal septum, and you need to give a nick, and then you need to do a abdominoperineal resection of the septum, then only the blood drains out. 25-year-old is having a routine smear and typically reported the findings. So you must be very sure how to interpret a pap smear, and accordingly CIN1, CIN2, CIN3, how do you classify the findings on histology? So depending upon the invasion into the underlying myometrium, and accordingly what is the appropriate management. So this comes under CIN1. So whenever CIN1 is there, then you should subject the patient to colposcopy, and if colposcopy is showing abnormal finding, then colposcopic directed biopsy. So in the Shaw's gynecology you have that approach to CIN, approach to cervical cancer. Take it as my point. 1 out of 30 questions in gynecology obstetrics without cervical cancer, pap smear or CIN, there will be no question paper. So that's the reason you have to feel that you are the president of Federation of Gynecologists and Obstetricians while reading Gynops. You should feel that you are Dr. Harrison descending down the Harvard internal medicine department while you are reading Davidson. So every time you should get into that mood of that particular subject, and to get that mood, if required, go and attend that few cases in the hospital whenever you are going down, right? So that's how you have to prop up yourself, and there are totally 450 topics you have to master. I think all of you have the topic list. If you didn't have, ask Raju will give you the topic list, and this topic list we declared about 4 years back, and we revised it every year based on any new topics are arising. Hardly any new topics arise. Only little rearrangement of priority of the topics, little here and there, that's all. So, but most of the times 90% of questions asked come from that 450 topic list. How much time you will take to read 450 topics? Hardly 200 hours. So if you spend 200 hours of your valuable youthful time, you will be into the top 50 ranks. Let me tell you, very smart preparation. You don't need to read even 1 minute more than 200 hours. Not at all required. And take as many mock tests as possible and try to see where you are going when applying those points which you read. So these are the things that you need to do the next 6 months before cracking the NEET PG. Now a 20-year-old primary gravida attends the gynecology department with vaginal bleeding at 14 weeks of gestation. Ultrasound is being shown in the figure. What is this called? Snowstorm appearance, which is typical of trophoblastic gestational disorder. So what do you want to basically do? Before you do anything, you need to do a histological evaluation. So that is the reason evacuation and curettage is the one which is fundamentally required. A 16-year-old comes to clinic with primary amenorrhea, otherwise normal, no pelvic or axillary hair, and the breast is well developed, and ultrasound is not showing, MRI is not showing any uterus. So this is a classical feature of androgen insensitivity syndrome. How many of you did this question wrong? Anybody? All of you are just no axillary pubic hair means straight go and answer Androgen insensitive syndrome. There is no other second thought. Exactly. That should be the spirit. Now, doctor, 38-year-old Paris woman underwent simple hysterectomy with ovarian conservation, and there is an endometrial carcinoma limited to endometrium. What is the appropriate next step? So, this is a classical preoperative imaging which shows the presence of endometrial carcinoma, which is of stage 1A if it is only limited to endometrium. So, total abdominal hysterectomy with bilateral salpingo-oophorectomy is considered to be the management of choice. Now, a vulval carcinoma is being shown and it has spread to number of lymph nodes, but and also it has spread outside the lymph node capsule. So, which stage of the vulval carcinoma it is? So, carcinoma cervix, carcinoma of endometrium, ovarian carcinoma, vulval carcinoma. These 4 genital carcinoma staging you have to be thoroughly sure about, doctor. So, it is stage 3C. 3C means it has spread to number of lymph nodes and also has spread outside the capsule that surrounds the lymph node is called as 3C. 18-year-old comes with urinary frequency. She has a lower abdominal mass and a 7 cm ovarian mass which has got a mixed echogenicity. CA 125 are normal. So, this is how you can see lipid deposition, then calcium deposition and hair, etc., etc. What is that called? Ovarian teratoma, which is very common in young girls. So, what is the best treatment in this given case? So, the fatty contents in the cyst, so it is a mature teratoma which are usually benign and common tumor of a young girl. So, basically depending on the histopathology you need to take a call. So, to get the histopathology you need to do laparotomy and removal of the cyst and examine it is considered to be the management of choice. 47-year-old perimenopausal lady had a pelvic scan for menorrhagia and has a 4 cm cyst in the right ovary as what you can see. And the CA 125 levels are 18, benign. So, what do you want to basically do in this case? So, a very important point you need to appreciate is any N-echoic, it is not throwing any echos. Is it throwing any echos in the ultrasound? No. Any N-echoic unilocular cyst is called a simple cyst. If it is throwing echos or it has got multiple septations inside it, it is no more a simple cyst. So, a unilocular simple ovarian cyst. What is the most important criteria? Whether it is a benign or malignant is the whole tension. But what is the size here? The size here is only 4 centimeters, less than 5. That's the reason what you need to do, repeat ultrasound in next 4 to 6 months is considered to be the management of choice is what you have to basically remember. A 26-year-old is being referred for colposcopy with a mild dyskaryosis and the colposcopic examination is being shown to you. The colposcopic examination typically appear to be of a low-grade cervical lesion. So, here you want to confirm that histologically. That's the reason colposcopy directed biopsy is considered to be the best next investigation whenever you are, when the appearance is looking like CIN1 is what you need to basically remember. 36-year-old has a persistent left-sided ovarian cyst and on the 4th post-operative day she developed chest pain and fever and she has got a bilateral equal air entry. So, what are the causes in the post-operative period for developing shortness of breath? First thing is atelectasis of lung. Why? Because after you do an operation on the abdomen, right, diaphragm is not moving properly because the pain in the abdomen and the lungs will undergo collapse if the ventilation is not proper and atelectasis will occur, that lead to fever and dyspnea. And post-operatively pulmonary embolism is always a complication. Pneumonia postoperatively due to aspiration or due to any nosocomial infection can also lead to development of fever with shortness of breath. So to do or prove anything, what is the starting point in case of a dyspnea postoperatively? Chest X-ray. So that is the reason what she should undergo. She should undergo a chest X-ray. Pneumonia, pulmonary atelectasis, pulmonary embolism, they are the common differential diagnosis as a house surgeon and a resident tomorrow. That should be there in your mind whenever you find in a post-operative patient. 27-year-old has a cesarean section, and at the end of surgery, urine is noted to be heavily bloodstained. A urgent CT urogram has been done. So what is the common thing post-operatively obstetricians and gynecologists will leave? A little nick into the ureter or a nick into the bladder. There are so many surrounding areas. Your hand goes a little uncontrolled myoclonic jerk out. Patient's bladder or ureter is out. So now you are all becoming surgeons in the era of robotic surgery, right? So after about 4 or 5 years, I should say, oh, this guy took MD entrance coaching with us. Now he is the top robotic surgeon of the world. Not India, world. Aim high, doctor, dream high. The more and more and more you dream that you have the power to achieve, that's the only way we will achieve. And honestly speaking, out of all our talent and caliber, we hardly don't use even 10% of it. 10% of it, and we die one day without fully exploring what we are. So that's the reason, have that in mind and think entrances, cracking entrances, finishing post-graduation, these are all small endeavors, let me tell you. There is many things that you can actually do. So that's the reason, raise up the occasion. If you are having fatigue, the common reason is you are reading too much theory, which is unnecessary theory, which is not asked in entrance. If you are really reading what is asked definitely in entrance, you won't get boredom. Let me promise you. Okay? So that's the reason, have a good strategy, clear definition on what to read, and then just spend 200 or 300 hours of your time, crack it, and then get into the residency. That's how we all got into residency. So doctor, in that scenario, whenever there is any bladder injury, post-operatively, you need to use intraoperatively or post-operative, double layer closure and continuous bladder drainage you need to keep for about 1 week. A 54-year-old nulliparous woman underwent vaginal hysterectomy and pelvic floor repair. Post-operatively, she has a Klebsiella urinary infection, and her vault is healthy, but in the pelvis there is a collection of fluid post-operatively. So what do you want to do for a pelvic collection of fluid? Already actually catheter is placed into it. So that is the reason you need to do an ultrasound guided aspiration of the fluid. That's what you need to do for a post-operative pelvic collections. 25-year-old presents with irregular periods, recent amenorrhea, partner's semen is normal. She also suffers from excessive acne, hair loss, and HSG is being shown. Actually, I should remove this word. HSG is shown to be normal, should be removed. We should give you this HSG and ask you to interpret what it is. Sorry, that sentence we failed to remove. So nowadays it almost takes about 1 full day of our time to compose image-based questions. Ideally, we want to compose 100 image-based questions in 300 total number of questions, and bring as much closer simulation as the actual examiner, right? How many of you have taken recent DNB exam? What is the proportion of images? 8 or 10 only. How about you? 10, not 100. Sure? That means only our state MD entrance guys scare us with the 60-70 images. Actual NEET examiner is not that scary, maybe, We don't know. Huh? Anybody took All India last time? In that, few people say they get about 25-30 images also. AIMS you have taken? AIMS I think 15-20 image based questions were there. So, but anyway, let's prepare as such they are going to ask 60-70 image based questions like in our state MD entrance last year. And if he asks less, that's good. But actually speaking, image based questions are more easier to crack than what is the length of eustachian tube, what is the diameter of urethra. They are all very difficult to crack. If you don't know, you have to close eyes and cry. I don't know Volke in the exam hall. So it's a case of polycystic ovarian syndrome is what need to be remembered.